my name is Chelsea Wagner. I am a genetic counselor at Billion to One, which is a molecular diagnostics company based in California. In that role, I do still see patients for prenatal screening, and then I also work a little bit on the laboratory operations side. So my only disclosure is that I do work for Billion to One, and I own stock options as well. I have quite a bit of information that I do want to cover with everyone today, and so I'm going to dive right in, but these slides hopefully will be available if you want to look at the agenda. But let's start by talking about all of these acronyms I'm going to be using today. So cell-free DNA or cfDNA, CFFDNA, NIPT, we've got a lot of letters up there. And if it's been a while since you've been in the prenatal space, just a quick reminder, NIPT is non-invasive prenatal testing, and it's a way for us to screen pregnancies for certain genetic conditions. And then cell-free DNA or cell-free fetal DNA, which I use interchangeably, although I realize there's an extra F in one of those. CFFDNA is what we actually use from a pregnant person's sample to give a risk assessment for certain genetic conditions. And so that cell-free DNA originates from trophoblast cells or placental cells. During the pregnancy, the placenta sheds cell-free DNA from the ongoing pregnancy, and that can be isolated, amplified, and sequenced in order to give a risk assessment for certain genetic conditions. We are going to talk a little bit about how we do risk assessment for ongoing pregnancies for cystic fibrosis, and it does involve a metric that we call fetal fraction, which is simply the concentration or the proportion of cell-free DNA in that sample we are looking at that is from the placental cells, or hopefully representing the baby that we are trying to give a risk assessment for. And fetal fraction can vary for many different reasons. Notably, I think about the farther along in pregnancy someone is, the more fetal fraction we would get in a sample, ideally, fingers crossed. And additionally, if there's one fetus versus multiplets, that will also increase fetal fraction. And then there are other maternal factors that can decrease that fetal fraction. So all of that to say, fetal fraction is going to come into play as we talk through cell-free DNA screening. And just to kind of give some context to cell-free DNA screening, it was first described, cell-free DNA, in 1948, but it was in the context of oncology and tumor cells, where secreting the cell-free DNA was isolated, and suddenly the research world was like, hey, this is an important biomarker. And it wasn't until about 50 years later that cell-free fetal DNA was identified. And about 10 years after that is when the commercialization of cell-free DNA started to be used. We've definitely seen an explosion of these NIPT technologies going from being able to detect common trisomies like Down syndrome, trisomy 18, trisomy 13, all the way up in to telling us more about a risk for certain microdeletions or single gene disorders. And so obviously and appropriately, I'm going to be talking about single gene NIPT for cystic fibrosis today. And in the prenatal setting, which is where I live and breathe and have been for over 7 years, ideally when we are looking at a pregnancy and trying to get a risk assessment for a fetus, then it involves maternal carrier screening, paternal carrier screening, and then diagnostic testing to get to a point where we have information about that current ongoing pregnancy. That being said, we know that preconception carrier screening is rare in the United States, so I hardly ever am in this scenario or this equation. We know that half of pregnancies are unplanned, preventing the option of preconception screening. 40% of babies in the US are born to singled or unpartnered individuals, so that partner isn't even available for a risk assessment. And then even when we do have all of our ducks in a row and we have a partner available for screening, 58% of the time those partners do not follow through with carrier screening, which leaves us with an incomplete risk assessment for a pregnancy, and honestly a lot of time to get to a place where we don't have much more information than when we started with. And so that's where single gene NIPT comes into play. It solves some of those workflow issues, knowing that we're hardly ever going to be in an ideal situation. And if our goal is to identify pregnancies that are at a high risk to have cystic fibrosis or other recessive conditions, how can we do that in a really efficient way? And so the assay that I'm going to be talking about today starts with a maternal carrier screen. And if a pregnant person is identified to be a carrier for cystic fibrosis of a likely pathogenic or pathogenic CF variant, they will be reflexed to our single gene NIPT assay. And we're going to get a little bit into the weeds about how that assay works in just a moment, but the takeaway is we get a lot of genomic sequencing data. We run that through a lot of complicated bioinformatics that I cannot walk you through, but I can give you a general idea about what happens there. And then we end up with a personalized fetal risk assessment. That being said, I'll stress this a few more times. This is a screening test, so it is relying on placental cells. This is not a diagnostic test, and anytime we receive a increased risk, high risk result, there's always a recommendation for prenatal diagnostic testing. And then there's a consideration of pre or postnatal diagnostic confirmation on all of our reports, but we do call that out for high risk results. And so hopefully with that workflow, you're able to see that there are a few advantages to this type of screening in pregnancy. We don't need a partner. It's a faster turnaround time than even if we had that ideal experience of maternal screening, paternal screening, get them scheduled for diagnostic testing, wait for your diagnostic results to come back. And most importantly, at the end of this workflow, you get a fetal risk assessment. So for that current pregnancy, what is the chance that pregnancy has cystic fibrosis? And that is very different than having a couple sitting in front of you and saying, well, you have a 1 in 4 chance of having a baby with cystic fibrosis. I will give you sort of the range of risk that we give with these types of results, but we can go up to a 9 in 10 or a 90% chance that current pregnancy has cystic fibrosis, or we can provide reassurance with a residual risk of less than 1 in 5,000. So you can see the difference in those risk numbers could really benefit patients that either knew they were carriers for cystic fibrosis going into a pregnancy, or most of the time, and what this test is really designed for, is for identifying people that did not know they were carriers for cystic fibrosis and did not know they were at risk to have a baby with CF. And so all of that comes down to how do we actually get that information? And so this is where we get a little bit into a lot of math. So I apologize because it is early in the morning. But just a quick review of what happens with a NIPT sample when it gets to a laboratory. And this is true for any NIPT assay. Basically, you're getting 2 or 3 tubes of blood. That is not a lot of volume to do a lot of really important testing. So what happens is the cell-free DNA is extracted from the blood sample. So we're actually working with that yellow part of this blood sample. That's the plasma, and it does contain that cell-free fetal DNA. And then what we want to do is we want to amplify that cell-free fetal DNA. We know that we're not starting with a lot of information, and we need a lot of information in order to make very precise risk assessments. And so we go through an amplification process, and there's something a little unique about the way that we amplify these samples that I'm going to go into on the next slide. But then once we amplify all of those samples, we run it through sequencing, we have our sequencing reads, and then it goes through that bioinformatics analysis where we're trying to look at whether or not a distinct paternal variant is identified, maternal dosage, and then that fetal fraction and something called molecule counts also comes into play. And don't worry, that last part of the analysis we're going to go into more detail about. But really that problem with the amplification step, sorry, I'll go back. Amplification is a tricky part of these assays because when you're amplifying something, you don't always know what you started with, you know what you ended with, but you're not sure what kind of happens in the middle. And there are some biological reasons why certain fragments of DNA may amplify at a different rate than others. And so a lot of this amplification bias leads to just a lot of uncertainty of what do we actually start with, and are we overestimating or underestimating? And so the solution is to add molecular markers or molecular yardsticks, if you will. And we call these quantitative counting templates, or QCTs. And quantitative counting templates are artificial molecules that have been designed to be added to samples. I think of them as like little fluorescent flags. We throw them in the sample, they light up, we know that they're there, and you add a certain number to your reaction to start with. And you know I started with this number of QCTs. You know that QCTs are designed to amplify at the same rate as those CFTR fragments. And once you do your amplification process and you get to all those sequencing outputs, you're going to start counting what you have. And what that is going to end up with is an increased number of QCTs because they would have been amplified. And you can use that equation to figure out how many CFTR fragments you're starting with in that original sample. So it is kind of a backwards math equation, but here's an example. If you start with 200 QCTs, you add that to your sample and you know you added 200 QCTs. At the end of your reaction, you end up with 2,000 QCTs. When you do your math, which I triple checked that this was 10x, but if I'm wrong, please let me know. The amplification factor is 10x. So that's telling me whatever I ended up with for my CFTR fragments, let's say 10,000, for example, I know that that was multiplied by 10 times because those QCTs multiply at the same rate as those CFTR genes. And so when I finish out this math equation, I end up with 1,000 CFTR fragments. Who's with me? Okay. I will say it's taken me about 2 years to get to a point where I'm like, I think I get it. So if you go home and you don't get it, that is okay and expected. But let's just imagine that my math is correct and we do have 1,000 CFTR fragments. The question then becomes how many of those fragments are disease-causing fragments versus wild-type fragments. And this is where the sequencing and that analysis part comes into play from our workflow earlier. So with molecular counting, the idea is we have a certain number of molecules and I want to know the ratio of those molecules for that sample. And this is also where fetal fraction comes back into play because I know that that sample isn't only representing my pregnant patient. We know that part of that sample is fetal fraction. So we want to take all of that into account. And again, it's more math. So if we think about starting with 1,000 CFTR fragments, which we know from our earlier stages, and we start doing all of our sequencing and we start counting up the proportion of wild type alleles to disease-causing alleles, we get to a point where we see about 50% of that sample has wild type alleles, 50% has disease-causing alleles, and we say, okay, what does that tell us? And that's where the fetal fraction comes into play. So in this hypothetical sample, which is very generous, but in an ideal world, we have 10% fetal fraction represented by 5 plus 5 equals 10. That leaves 90% of that sample or 90% of those reads that we're looking at representing the maternal status. And then because we've done a carrier screening on mom or the pregnant patient, we already know that we should be seeing one wild type allele and one disease-causing allele. Now, this math looks a little bit different for moms that are affected with CFTR, but we are able to do that as well. But keeping it simple, just imagine mom is a carrier. And then we see here that the math ends up being, in total for this sample, we have 50% wild type, 50% disease-causing. With everything we know about the fetal fraction, that means this fetus is a low-risk fetus to be affected with cystic fibrosis. Now, some of you may ask, are you going to report out the carrier status for that baby? And the answer is no. So the way that we are reporting out our results is a risk for cystic fibrosis or CFTR-RD disorders. So we're not reporting out carrier status. If I were to look at all of the bioinformatic data, I could probably tell you with very high certainty baby's carrier status, but that's not our goal. Our goal is to identify those high-risk pregnancies. So these high-risk pregnancies, this is actually what the math is going to look like. We take all of those reads. We know, again, we've got that 90% of those reads are going to represent mom and 10% are going to represent baby. And then when we are looking at the proportion of those alleles, we see that a smaller proportion are wild type alleles and a higher proportion are disease causing alleles. And plug it into all of our computational math and we figure out that there are more disease causing alleles than what we're expecting. So this is going to be a high risk pregnancy. Now, those numbers, high risk, low risk, those are sort of our general categories that we bucket our risk scores into. But like I mentioned earlier, we have a really wide range of residual risks that we give. And it does depend on that sample itself. So I've seen risks that are at the very far end of our spectrum where we can be very reassuring that there's less than a 1 in 5,000 chance a pregnancy is affected. I've also seen like a 6 in 10 chance that a pregnancy has cystic fibrosis. So again, it highlights that this isn't a diagnostic test. It's not getting you to 100%, but it does really move that needle one way or another. What I showed in terms of this counting, it's helpful if we are assessing to see if a baby is homozygous for CFTR variant, but we know that there are compound hits. And so the way that we address that with our assay is we also, at the same time where we are looking at that dosage, which is looking to see does the pregnancy have that same maternal variant that we identified on the carrier screen. At the same time, we are looking to see if there is a distinct paternal variant identified in that sample. So the idea would be if mom is an F508 carrier and we do our single gene NIPT assay, and let's say we find an R117H, we know that didn't come from our maternal carrier because we've done her carrier screening. She doesn't have R117H. So that is a distinct paternal variant that is very likely coming from those placental cells and very likely representing the fetus. And so we do paternal allele identification. We cover over 97% of paternal variants with this type of paternal allele identification. And then we add that together with whether or not we think the pregnancy has inherited the maternal variant, and voila, we have a fraction, which is helpful for some patients, not helpful for others. So we also bin those results to low risk, high risk, and then you see this middle category, it's called decreased risk, and this is often given to our high risk couples, so couples we know coming into the assay, they're at an a priori of 1 in 4. With our technology, we cap our risk reduction at 100 times risk reduction. So that means the lowest residual risk we can give high-risk couples is a 1 in 400. And then we can go to 9 in 10 as well with those couples. And again, anytime we're issuing a result, even for low risk, we will recommend postnatal testing or diagnostic testing if desired, and then obviously screening for a partner in future pregnancies is also on our list of recommendations. And you might ask, well, that sounds really cool, but does it work? And the answer, in short, is yes. So single gene NIPT, there's been 2 large outcome studies where they've followed up with any high-risk result that was issued to see was that concurrent with a neonatal outcome. And what we see in these 2 different papers, they're both published in 2023, but in 2 different journals with 2 different cohorts, we see that individuals that received a high-risk result most often were diagnosed or confirmed to have a diagnosis of CF or some of these. The graph on the left has only high-risk CFTR results, and then we do screening for additional conditions that are not only cystic fibrosis. So the goal of these graphs is really to just show that when we do issue a high-risk result, very often, very frequently, we are correct. And same with low-risk results or indeterminate or intermediate results. So if you look over here on this right-hand side on this graph, I actually don't know if you guys can. Yeah, you can. Okay. If we think about results that were issued that were about a 50% chance to be affected, you see about 50% of the babies were affected. And so as the residual risks are given, we're seeing that same proportion of outcomes that you would expect. So the math checks out. There are a few considerations that I will mention that are specific to the assay that I'm talking about. However, if you're ordering this testing or if you're talking to providers in your system about ordering this testing, I would encourage them to reach out to the performing laboratory and just double check what their policies are. But what I'm familiar with is the policies regarding reporting out VVCCs. So we do report out VVCCs. If it's identified on a maternal carrier screen, that will be reported for maternal carrier status, and it is going to reflex and do that single gene NIPT risk assessment. There is special language that goes on those reports that's associated with those variants. Same idea with R117H. So we will reflex to single gene NIPT if that's identified on a maternal carrier screen. And there's additional special language that goes on those reports, just highlighting that there's a really wide clinical spectrum, and it really depends on what other CFTR variant an individual has. And then I get a lot of questions about poly-T tracks. So in case you are curious, we do report out maternal poly-T tracks. We don't report out poly-T tracks for anything else. So if we were to identify like a paternal R117H variant in the single gene that was not maternal, we are not going to be able to report out those poly-T tracks, which means I can't give fetal poly-T tracks. I can really only give you CFTR variants. There are a few things to keep in mind, and again, this could be laboratory or assay specific, but when we're reporting out maternal carrier screening or the identification of paternal variants, we're only reporting out likely pathogenic or pathogenic variants, and all of the variants seen go through a formal curation process, and the performing laboratory has to designate that as path or likely path. So if you have a variant, you're not sure if this would reflex to single gene NIPT or be reported out, again, I would check with your performing laboratory. The other thing I want to briefly chat about, and again, I don't have too much time, but there are only certain variants, maternal CFTR variants, that we can do dosage analysis for. So this is what is the chance the fetus inherited a specific maternal variant. That being said, we actually covered the most common CFTR variants on our dosage assay. Typically, a good rule of thumb is if a variant accounts for greater than 1% of the variants in CFTR2, it is likely going to be dosage eligible. That being said, check with your laboratory, make sure that this is going to be an informative test. If you have a mom that's a carrier, we will still do a maternal carrier screen. We will still do a single gene NIPT assay. However, the highest risk assessment you would be able to get in that scenario is a 1 in 2, and that would be if we identified a paternal variant that was not the dosage ineligible variant. So lots of caveats, but always happy to talk through those cases if you have something that you're interested or wanting to talk about. And then finally, because of that maternal dosage eligibility, we don't do maternal dosage for extremely rare CFTR variants. So if you do have a couple that is at risk for homozygous rare CFTR variant, it's very likely that this assay isn't going to be informative, because not only we wouldn't be able to tell you, did the fetus inherit the maternal variant, but there's also not a distinct paternal variant to identify. So that screening is not going to be useful for that couple. It's going to keep you right at 1 in 4. Thankfully, the dosage ineligible and those rare homozygous variants that we want to take into account are a very small percentage of diagnosed CFTR genotypes. So potential updates in the future, but that's kind of where we stand right now. And with the last few minutes of my time, I just wanted to talk a little bit about, I think that technology is really cool, but what does that look like in practice? And so we know that single gene NIPT workflow is likely a better workflow for identifying at-risk pregnancies than traditional carrier screening. And with this information early on in a pregnancy, it allows parents, families, caregivers to pursue diagnostic testing, have that time to adjust to a diagnosis, have that time to connect with families and support and do their own research, and really just have that breathing room that is not available when you have a newborn that is being diagnosed, or that you're jumping through all of these hoops. And so we know that newborn screening is a great tool for identifying and diagnosing infants with CF, but it's different in every state. And really, if we can just keep adding tools to our diagnostic CF toolbox, that's really the purpose of these types of screens. And then I have 5 seconds left. CFTR modulators. I know you all know about these. There are great studies that are coming out about potential fetal therapeutic benefits. So imagine if you could identify a high-risk pregnancy for cystic fibrosis, you could do diagnostic testing at 16 weeks. You have a diagnosis, a genotype, and potential candidates for modulator therapy in utero. That is all I will say on that. But there is some great information, and there will be a poster that talks a little bit about the amount of pregnancies that are identified in modulator eligible. Oh, I have time. Whew. Oh, gosh. Okay. So when we think about modulator eligible genotypes, about 90% of prenatally diagnosed babies with CF are modulator genotype eligible. And when we took a look at all of our high-risk CF test results, we found 40 pregnancies that had a high risk greater than 1 in 4, so greater than 25%, and 38 out of those 40 that we identified with our assay were predicted to have at least one CFTR variant that's eligible for modulator therapy. And so really, if you think about this, again, it's the benefit of time. And I feel like that's one thing we could all use more of. So if you have time to adjust to this diagnosis, to think about modulator therapy, to potentially have this in utero, there is, again, just a shift in the landscape of how early we can detect cystic fibrosis and how early we can begin intervention if that's something that's desired by the family. And so, deep breath. These are all the things to take home from today. Hopefully, I've demonstrated that single gene NIPT is an alternative workflow for identifying high-risk pregnancies for cystic fibrosis. And this type of risk assessment provides a fetal risk assessment without a lot of the complicating factors that we often run into in the prenatal world. And the fetal risk assessment has a high concordance with neonatal outcomes. So, so far, this test is a really good indicator of identifying those pregnancies. And I, again, will just end with time. I think this test allows time for families, can identify people that didn't know that they were at risk to have a baby with cystic fibrosis. And so just having that time back for those families is extremely important. And I know I ran over just a little bit, but if you do have any questions, you're more than welcome to email me. That's my personal Gmail and my work email. And I don't know, do we have time for, we do have time for questions.
Yeah, thank you so much for a great presentation. And I'm guessing there might be questions. We have about 5 minutes, so we will be glad to take some live questions now.
Mm-hmm. Yes. Mm-hmm. Yeah, great question. So the question was, if we are performing this on a person with cystic fibrosis, what are the risk reductions like? What are those risk ranges? So we take into account that information in our a priori risk. So if you think about all of the reports that you might see, usually we're starting with a general population risk, which is just based off of ethnicity-specific carrier frequencies. But if we do a carrier screen, identify 2 CFTR variants, that a priori risk is going to start much lower. It's actually going to be halved from the general population risk because we are expecting 1 maternal variant to be passed on to the fetus. We can still get to a 9 in 10 for an affected fetus if we're able to find a distinct paternal variant. The lower end of the residual risk, we won't go to 1 in 5,000, we'll go to about 1 in 2,500. So basically take any of those caps that I talked about and cut them in half. And that's how most of the affected individuals' results turn out.
Since they're recording the session, if you wouldn't mind coming to the mic, please. Thank you.
Yeah, great question. And I didn't go into a ton of detail, but when we think about paternal variant coverage, when we are doing that CFTR sequencing on the cell-free DNA and looking for those distinct paternal variants, it is an amplicon-based NGS platform. And what that means is it's not comprehensive sequencing, but these amplicons are based in all of the exons of CFTR, and there's very little coverage that's missed, but the paternal variant detection is greater than 97%. So it is possible that a rare paternal variant may not be picked up on this screen. And if that is the case, then that's going to limit the risk assessment that we give. And it's really important for us to know ahead of time if that is true or what the paternal variant is. And oftentimes we will add manual language that we know there is a paternal variant suspected for like this couple, but our assay is unable to detect that. Yes.
Can I ask a question related to that? So if usually getting a paternal sample is not part of your normal workflow, but if you want a further reduction in risk, and the paternal sample is available, then that paternal sample can be sent in.
Yeah, so we do accept male carrier samples or partner carrier samples. That is really just to perform carrier screening, though. So it doesn't actually get incorporated into the fetal risk assessment. Reason being, we know that non-paternity is something that we contend with, and this test can identify non-paternity. And that residual risk that we give, that less than 1 in 5,000, takes into account the possibility that the partner is a carrier for a gene that is not covered on our single gene NIPT assay. So while it's helpful, certainly for future reproductive risks, and very likely if you're going to go on and do diagnostic testing, most labs are going to want paternal and maternal variant documentation. It's something that's not required to still give that residual risk, the lowest residual risk.
And potentially it could provide advantage of knowing the poly T status because you can provide that for the father.
Correct.
And you don't do TG?
We do not. I get that question a lot too. Any other questions?
Other questions? Is there any in the app? I have one question,
Yeah.
and then I think have 30 seconds left.
Yes.
But so if maybe you mentioned this and I need just further clarification, but is it possible that you would find a mom to be a carrier on your carrier screen, but it would be a allele that a CFTR variant that would not be eligible for dosage for the fetal risk assessment?
Yes. So you sometimes can get the maternal carrier status, and sometimes that variant is not eligible for the fetal risk assessment. And so when we see that, or if we have notes ahead of time, we do try and reach out to ordering providers and say, hey, this variant is not dosage eligible. But that being said, the residual risk calculations take into account the fact that that maternal variant is not eligible for dosage analysis. And that's why we really do see a really big span of these residual risks. It's not always 1 in 5,000. It's not always 9 in 10. It's truly personalized to what we're seeing in that pregnancy.
And you update your assays, so from time to time, they become more
Better.
variants become eligible.
Yeah, so if you go and look at our first validation paper, there was some confusion, but you might hear that they only do dosage for F508. That's not true, but we have recently updated our assay in the past 6 months and added a lot more maternal variants that are eligible for dosage. And I will just share a quick clinical story. I talked to a patient who had our test 2 years ago. Her variant was not dosage eligible, but her partner was a known carrier, so we got her to a 1 and 2 for that pregnancy. I spoke with her 2 weeks ago, and her maternal variant is now dosage eligible, and we just received her sample at the laboratory. So we're going to be able to give her a lot better refined risk assessment for this pregnancy because of the updates that we've had.
Thank you so much for a great presentation, Chelsea.
I'm just going to skip down a few slides here to introduce Dr. K. Our next speaker I'm pleased to introduce is Dr. Denise K. Dr. K is going to talk about cystic fibrosis newborn screening in New York State and the impact of sequencing. Dr. K has worked with the New York State newborn screening program at the Wadsworth Center, New York State Department of Health since 2009. Her background is in genetics and genetic epidemiology, and her work is focused on addressing challenges in newborn screening, including improving current methods and algorithms and developing and implementing assays, including expanded genetic analysis for existing and new conditions. Dr. K was responsible for onboarding gene sequence analysis for CF screening in 2017, which resulted in a greater than 80% reduction in referrals. She is active in the National Newborn Screening Community, working with the Centers for Disease Control and Prevention, the Eunice Kennedy Shriver National Institute for Child Health and Human Development, and the Association of Public Health Laboratories. Also, fun fact for Dr. K. Besides one trip to Canada, Dr. K had not traveled outside of the U.S. for fun or work until 2021. And as of just a couple of weeks ago, she has now traveled to 15 different countries on 4 different continents, and you must have seen and learned so many amazing things in your travels. Welcome, Dr. K. We're looking forward to your presentation.
Yeah, that's the right one, the middle one. Thank you. So I have no relationships to disclose. I'm happy to be here today. Thank you for the invite. I'm going to talk about the New York State newborn screening algorithm, which is a bit different than most states in the U.S. I'll talk about our rationale and justification for implementation of a sequencing step, the impact of the algorithm change on newborn screening, genetic counseling and clinical care, and some quality improvements that we've made. So a quick background about New York State. So screening is mandated by state public health law in New York. All babies born in our state are screened. And I'm going to turn this on. I don't want to go over. Thank you. My fail-safe. So all babies born in New York State are screened. We have a religious exemption. We have a single central lab in Albany, which is where I work. We currently test for more than 50 conditions, plus we have a few pilot programs. We screened just under 205,000 babies in 2023, and our birth rate has drastically declined. We have 116 birth hospitals and 10 CF newborn screening specialty care centers, and we have a lot of representation from our care centers here today. So just a quick refresher on our algorithm. So we started screening in New York State in 2002 using an IRT DNA algorithm. And if you look on the right, I'm not sure. This is what most IRT DNA algorithms look like in some form. So in New York, we screen all babies for immunoreactive trypsinogen. We use a floating cutoff. The top 5% get reflexed to a variant panel. Between 2002 and 2017, that ranged from 30 to 39 variants. And then babies are considered screen positive if they have 2 panel variants, 1 panel variant, or no panel variants, but ultra-high IRT, which I'll abbreviate as VHIRT throughout. And the reason why we referred babies with no or 1 panel variant is to identify babies with CF who have 1 or 2 rare variants that weren't captured by the panel. And that's because we know New York State is one of the most diverse states. And these IRT DNA algorithms are still used by most states in the US. There's a lot of variability, but the general algorithm is what most states are using. So what's the problem? You probably are all very familiar with the problem. There's a high number of false positive CF screens when you're using a limited panel. IRT is also a poor biomarker, but it's all we have. So the problem is driven in part by the need for, in New York, for us to have referred carriers and babies with ultra-high IRT. Again, we're diverse and panels aren't comprehensive. This leads to parent anxiety and burden on families and the healthcare system. And so California had been sequencing since they started, since they started screening in 2006. And so we thought, can we use that model, add third-tier CF sequencing to our algorithm, refer only babies who have 2 variants, and then eliminate referral of carriers and babies with ultra-high IRT. At the time we were thinking about this, next-gen sequencing capabilities started emerging at our center. We got a couple of instruments, and Illumina released 2 FDA-cleared next-gen sequencing assays, one that targets 139 variants and one that performs sequencing of the coding region of the gene. So we thought, let's give it a try. And so the first thing we had to do was determine if it was feasible. So those kits are validated for DNA extracted from whole blood. So we validated the kits, they worked great. We assessed logistics and workflows and making sure that we could return results in a reasonable turnaround time. And we also, at the same time, started looking at our New York State CF variant spectrum. So we took an 11-year data set, identified all the confirmed cases, and tested them using these platforms and said, is sequencing necessary to identify all New York State patient alleles? And if it is necessary, can we justify adding sequencing to our algorithm? So this shows the most recurrent variants that are in our population. So we had 439 CF patients in that 11-year period, and we detected more than 130 variants. These are the 20 most common, ordered by frequency. And sort of in the middle columns, you can see some of the most common variant panels that were in use at the time, targeting the ACMG 23, 39 variant panels, and the Illumina 139. And so these are the variants that were detected in our patients. Those that have blue color means the variant detected in our patient is targeted by that panel. And so what you can see are gaps. So some of the most common variants in the New York State population, recurrent variants, were not present on those panels, including the 139 variant assay. And so our conclusion was that CFTR sequencing was required to detect all New York State patient alleles. So we were able to justify addition of third-tier sequencing for a subset of newborns in our state, those with 1 panel variant or ultra-high IRT. We demonstrated high CF allele diversity with both recurrent and rare variants not on panels. We validated the assays for use with dried blood spots, showed feasibility, and we projected a significant reduction in the number of false positive referrals with implementation of a 3-tier IRT DNA-seq algorithm and referral only for babies with 2 variants identified. And we were actually able to justify this to the Department of Health by demonstrating that the added cost of sequencing to our program was about equivalent to the cost savings by not referring all of those carriers and unaffected babies for these clinical workups. So if you look on the right, kind of in the middle, this is our old IRT DNA algorithm. You can see that, okay, good. And then on the right is our new algorithm. And basically what we're doing is adding this third tier. We still use an IRT biochemical immunoassay, screen the top 5% for a variant panel, but instead of referring babies who have 1 variant or ultra-high IRT, we sequence them. We also screen for deletions and duplications across the gene, and we do screen for poly-TG and T genotypes for babies that make it to the third tier. Babies with 2 variants are the no-brainers, right? Those get referred. And so the difference is that with the new algorithm, babies who have one variant or no variant would have been referred using our previous algorithm. And so this more comprehensive analysis allows us to be more confident that we're screening for most of the disease-causing variants and permits referral only if 2 variants are detected. I just want to briefly mention that we've used 2 different kits for our sequencing. And so we started out by screening using the Luminex 39 variant panel, followed by the Illumina assay. We switched in 2019 to a custom assay that we built with a company called ArcherDX. And basically, we've combined our 2nd and 3rd tier into a single test. It's just split by analysis. So every baby gets next-gen sequencing, single DNA extraction, single library prep, single sequencing run. Those that make it to the 2nd tier, we read out a panel of variants. If they have 1 variant or ultra-high IRT, then we unblind the rest of the sequencing and read that. What's really nice is that our panel is flexible. It's really just a VCF file that you feed to our pipeline, and it calls out the specific variants. So it's not a lab test that we need to revalidate. Our panel is based largely on CF-causing variants in CFTR2, like 99.6% are CF-causing. We have a few extras. So I usually use this slide to walk through our workflows, but I want to focus on interpretation for this session. So what do we do with the variants that we detect by sequencing? We have a custom database that we use to track all of our variants. When we detect a variant, we annotate it. We pull information from everywhere we can. The first thing we do, though, is look to CFTR2 because they have the answers. So if we find that a variant is CF-causing, we report it as CF-causing. Variants of varying clinical consequence are reported as variants of varying clinical consequence. We don't try to call them likely path or path. They're their own separate category. We don't report non-CF-causing variants. And if variants are not in CFTR2 or unknown, which the unknown problem went away as of the release in CFTR2 yesterday, yay. So in those situations, we classify variants using ACMG guidelines. Our program defines actionable or reportable variants as those that are CF-causing, path, likely path, varying clinical consequence, and also variants of uncertain significance. And I'll come back to that. So babies with 2 actionable variants are referred for sweat test. So this is what our data look like as of 2023, our last complete year. We screened about 205,000 babies. We test about 1,000 specimens a day, including repeats. About 9,400 were sent to the Tier 2 panel. That's the top 5%. And then about 790 were sent to 3rd tier sequencing analysis. And in the end, after all the testing was complete, we had 104 screen positive referrals with 2 variants, 505 carriers, and 179 screen negative. And just remember that using our old algorithm, this group here would have been referred. And that corresponds to an 87% reduction in referrals. So it's had a huge impact on our referral rate, which you can see here. This shows the annual number of referrals in New York State. The bars show the number of babies split into the type of referral. So those with 2 variants are shown in blue. 1 variant referrals are shown in yellow, and then the ultra-high IRT category is shown in gray. And you can see that through time, we've made some changes and to reduce our referral rate. The numbers here show the median number of referrals per year. And what you can see is that right before our algorithm change in 2017, we were referring about 600 carriers per year and about 200 babies with ultra-high IRT no variants. And then you can see here is where we're at today, where some of those babies that were in the carrier group or in the ultra-high IRT group have shifted to the 2 variant group. This is a closer look at the referral or the screens. Any baby who's had genetic testing since we implemented the test in December 2017, and annually we now get about 100 to 120 referrals. about 500 carriers, and 160 to 70 babies who would have been referred with no variants are now considered screen negative. So let's take a look at the 104 screen positive babies in 2023. This is really interesting. So if you look on the right, we had 26 babies with CF. 23 of them had 2 panel variants, so 90%. 2 babies had 1 panel variant and 1 rare variant only detected by sequencing, and 1 baby had 2 rare variants not on our panel. So this shows us that some rare disease-causing variants are still absent from the major databases and literature. So these are the 3 babies. Let's take a look at those. So this table shows all of our cases in 2023, confirmed CF cases. This does not include CRMS, CFSPID, those that had fewer than 2 panel variants. Our current panel is 369 variants. So in the first case here, we have a baby with 1 panel variant, CF causing, and 1 splicing variant that was really easily predicted to be pathogenic. It's not in CFTR2. The baby had sort of intermediate sweat chloride levels, but the baby had had surgery for meconium ileus, was pancreatic sufficient, treated as CF, and the case was closed by the care center as a confirmed CF. The second case had a CF-causing variant and a variant of uncertain significance. So that variant would probably not be reported as of uncertain significance the next time we see it. It would probably make it to likely pathogenic. And then the third was in our ultra-high IRT category. This baby was homozygous for a likely pathogenic variant and a VUS. So does anybody want to take a guess which population group these 3 babies are not part of? They're not European, right? So we look at these babies. One had 2 Bengali parents, and the other 2 are actually both Ecuadorian. So this is why we do what we do, why we look at the sequencing. I will say that as of the CFTR2 release yesterday, which we've all been stalking, the splicing variant in that first patient is now in CFTR2. The others are not. And that's probably just because we haven't seen them enough. They're rare. So this confirms to us New York is diverse. New York State CF patients have rare CF alleles not targeted by large panels, including VUS. And sequencing maximizes the detection of babies with CF, regardless of their ancestry or the likelihood of CF in that population, or even the perceived likelihood of CF in that particular population. So you might be not so familiar with your newborn screening program. You might be wondering, how many variants does my state screen? That changes quite frequently. It's hard to get a real good static graph showing who does what, but basically most states as of 2023 were screening using one of the 2 Luminex panels, so 39 or 60 variants. 13 labs are testing between 60 and 72 variants. 12 are still only screening for 39 variants. And I think at least 5 are doing more extensive panels or next-gen sequencing. Importantly, in 2023, there were more than 700 CF-causing variants in CFTR2, and the largest commercially available panel is 139 variants. And that panel is really only FDA approved for DNA extracted from whole blood. So the LDT rule the new FDA LDT rule has a lot of implications. Taking a look into our 104 screen positive infants, what were their diagnoses? So 25 had CF out of 104, but 57 were asymptomatic and were classified as CRMS CFSPID because their sweat chloride was less than 60. And so this is the flip side of sequencing. This is sort of the bad side of it. You get a large increase in your number of CFSPID cases. So we've drastically improved our positive predictive value of screening. We've increased it by more than 6-fold. But our CRMS CFSPID to CF ratio is now close, it's 2.3 to 1. So because of this, and because we like to always improve, we've been working on several QI projects. We have a New York State Newborn Screening Consortium. Our program works very closely with our CF care centers, our genetic counselors. And so one of our recent QI projects was to examine the impact of CF sequencing on identification of babies who are positive but don't have CF. And so we looked at the first 3 years of data. We had 1 to 4 years of clinical follow-up data on these babies, and we took a look at what their outcomes were. But the first thing we noticed is that we have 10 centers in New York State. We have a lot of differences in how these babies who are challenging to evaluate and diagnose and follow anyways, it's a lot of differences across the centers. And so I think what you all will be most interested in are what proportion of our babies in this difficult to help with prognosis, this group of babies, what proportion are receiving genetic counseling. So what we found overall among 263 screen-positive babies that don't have CF, we found that 37% had met with a genetic counselor across all centers. 34% were provided genetics education by one of their healthcare providers at the CF center. 18% were marked as having nothing at all. And then another 12% were unknown, but my suspicion is that those are also no's. And if we break it down by center, I mean, the range was huge. So we go from essentially 0% genetic counseling to 100% genetic counseling in our centers. And you can imagine that has a lot to do with which centers have a genetic counselor that has FTE dedicated to their CF center. So you may have noticed that I have a couple of slides that talk about carriers in our diagnoses. I said we don't refer to carriers any longer. We do find some babies who are screen positive with at least 2 actionable variants, but all of the variants are in cis on the same allele. So they're actually carriers. We started offering phasing to our families about 6 months after we started screening. It's optional, offered to parents of screen-positive infants after referral, because this is handled by the centers, not our program. Blood samples are collected from mom and dad, or just one parent, if one parent is available. Samples are sent back to us with informed consent, and we test just for the variants detected in the baby. You can see on the right what proportion are getting tested by us. There's a lot of biases by center, what the variants are, what's known about them, the family history, prenatal testing, et cetera. But if we take just the babies that have had phasing done, what we find consistently each year is that about 15% of the babies that are phased have all of their variants in cis. This is really important because if there's no clinical indication for follow-up in these babies, if their sweat chloride is low, these babies can be reclassified as carriers. And I think even some centers, if the phasing shows that the variants are in cis, they actually don't need to do the sweat test. It depends on the order of operations. So you can see this list of all of the complex alleles that we've detected in this group of CRMS CFSPID patients. I'm not going to go through it, but we published it in 2024. But I do want to highlight R117H. So I think we all know when it's in cis with 5T, it's CF causing. In cis with 7T, it's a variant clinical consequence variant. If they're both detected, we kind of assume that they're on the same chromosome. We did that for many years in newborn screening. You detect both, the baby's a carrier. So we phased those babies in our program, and this is a table from that publication, and I added data from the last 2 years of screening and phasing, and really what we find is that only half of them are in cis. The other half are in trans, and this is specifically limited to babies with R117H and 5T12TG. We do genotype the poly-TG. So R117H and 5T12TG may be in cis, and you have a CF carrier, or they're in trans, and they have 2 variant clinical consequence variants, and they're at risk for developing CF, a CF-related disorder. That being said, our sample size is small. Speaking of 5T, 12TG, if we look at our CRMS, CFSPID group, they all have at least one VCC or VUS, pretty much by definition. And our largest contributor is 5T, 12TG. We only screen for and report that in the babies that make it to the third tier. The reason we report it, it's considered a variant of variant clinical consequence. The penetrance is low, but California reported 6% of babies classified as CRMS convert to CF by 8 years of age. So there's some risk. I will just point you to a poster that Charlotte Close is presenting on Friday, poster 376. We have a SIP award that is specifically targeted to engage and get new genetic counselors or genetic counselors who were in previous roles engaged in their CF centers. Just to summarize, so the benefits with more comprehensive CFTR analysis and referral only when 2 variants are detected, we've reduced our referral rate by more than 80%. We've eliminated the burden of false positive screens for most families, and this is associated with reduced healthcare costs. Our positive predictive value is increased more than 6-fold. These babies essentially have a molecular diagnosis at birth. When they're first presenting to their CF center, they know what the variants are. We have found that despite a slightly longer turnaround time for the next-gen sequencing technology, our babies are still promptly referred and diagnosed. We've actually found a reduction in cases lost to follow-up, and that's because centers' caseload has drastically increased from us, so they can really focus their attention on getting every single baby in. And then the disadvantages, there is that slight delay in turnaround time. It's a few days, a couple of days, business days. There's different infrastructure and expertise needed to do next-gen sequencing. We have a core facility at Wadsworth that does next-gen sequencing for newborn screening and all of infectious disease. So we prepare the DNA, we give the core our DNA plates, they prepare libraries, they sequence, and they send us the data. And we have a bioinformatician who set up all the pipelines to do the analysis. There's challenges in variant interpretation. We detect VCCs and VUS. Variants might be in CIS, but that can be resolved by parent phasing. I do want to point out that we sequence 9 disorders, genes for 9 disorders in our program. And we do a lot for CF, right? Because we're testing the top 5%. So we're testing a lot of samples, screening a lot for genetics. But it's so much easier than looking at variants for other conditions because we have CFTR2. We have nothing that comes anywhere close for any of the other conditions that we screen. There's nothing as reliable. We've increased our CRMS CFSPID ratio to 3 to every 1 CF case. It's actually lower than 3 now. And that's because of our detection of VCCs and VUS. Physicians do monitor those babies for conversion to CF. They try to get them in for repeat sweat testing. And that's an entirely new set of challenges for families and the healthcare system. And really, CF sequencing might not be practical or necessary for all newborn screening programs. And I think that depends a lot on the population structure. There's also a lot of logistic barriers like cost and program size. Like I'm very lucky to work in New York. A lot of newborn screening programs are much smaller. So some ongoing work. We are updating our tier 2 panel. We were about to deploy our 700 variant panel, and then we got the new update, which is almost 1,100 CF causing variants. So we're gonna get that ready to go. So we'll be screening our babies for the recommended CFTR2 panel. We're still collecting follow-up for babies with CFSPID CRMS. We're monitoring for possible CF symptoms. And I feel like this one is really important. We are working on assessing methods to minimize the number of babies with CRMS CFSPID that are identified as screen positive who won't ever have any CF symptoms. We really want to stop medicalizing those children who may never develop any CFTR dysfunction that presents clinically. So we do have a CF Foundation SIP Award. Thanks to the Genetic Counseling Group for inviting me to talk today. And I want to acknowledge all of the work by the Newborn Screening Program Lab, the Genetics IRT Follow-Up Program, our consortium, and especially our care centers who are very engaged in our program. So thank you very much.
That was great. Dr. K, thank you. Do we have questions?
That was fantastic. I feel like I know a lot about New York State newborn screening, and it turns out I didn't know much. So I'm interested in your thoughts, and maybe you're willing to expand on this, and maybe you're not, about reducing the number of CRMS, because the obvious answer is to either stop reporting VCCs or stop reporting VUS, or pick and choose which of those to report.
So
What are you thinking?
I'm trying to ease our doctors into thinking about this, because the idea at first was we want to make sure that any baby who has CF is caught early. What we've seen from our data is that none of the babies with CRMS CFSPID have developed CF. We've had 2 that have converted to CF much later, and the symptoms are not failure to thrive in infancy. So that the target of newborn screening that we are mandated to screen for is CF, not CRMS. I think in the beginning we had that fear of missing someone. I think now we've collected data that says those babies that we're identifying are not benefiting from newborn screening and having this CRMS diagnosis at birth. So my hope, you're not recording, right, is that 5T12TG, I think we can eventually stop reporting that. That being said, one of our cases that converted to CF at a couple years of age, their sweat chloride went from the sort of high 30s. They had a couple of QNS and then eventually hit 60. That's the only one out of 80 just in the first 5 years. So yes, we are actively working on it. I'm sorry.
I said noted.
So if CFTR2 could change that designation, that would be really helpful. Just take 5T12TG and make it non-CF causing, and
I think there's probably data to support that. I don't know if it's
Yeah.
enough for us to change the call, but
yeah. So we're still looking, and we're working on a procedure to take a look at all the variants that we've reported to date. What are the outcomes in those babies? And once you detect enough of them in some number of babies who don't have CF as babies, we could probably start reclassifying those to likely benign. And so that is also something that we're working on discussing.
thank you.
Thanks, Karen. I do want to add one piece that I always forget to say. So when we don't report carriers any longer, or we don't refer carriers any longer, but we do report carrier status. So that information, if a baby is a Delta F508 carrier, that goes in the newborn screening report with a recommendation for genetic counseling. We can't mandate it, can't require it, we recommend it. We also send a brochure to families, I think it's 3 weeks or a month later, that explains that reminds them that their baby is a CF carrier and what that means for their family.
I wonder if now that we have more data, especially if we combine data across states, if there could be a potential correlation between children that have a higher IRT and those who convert to CF and who have the 5T12TG situation. I just wonder if there's an IRT correlation.
We did look at that, a very sort of, well, we only have 2 that have converted to CF. So the IRT levels don't correlate with babies who sweat positive versus sweat negative. But whether that has some influence on those that convert to CF eventually, it's possible.
Obviously, we just from my experience of just a couple of kids, the ones who have converted have had high IRTs, but doesn't necessarily mean anything.
Yeah.
We do have one question from the chat. From Ellery Wollen. One of the benefits I see of meeting with families who have a false positive newborn screen, so carrier only result, is that I get to do family education and facilitate carrier screening, sometimes identifying couples that are at risk to have a child with CF in the future. Have you seen any increase in CF incidence as a result of this step, or do you foresee that down the road?
No, so we do have missed cases every year, but they're low IRT. So they're not getting missed by the panel necessarily, they're getting missed by, no, that's a different question. So you're asking, has the CF incidence increased because we are not necessarily getting the word out about carriers to families? No, our CF incidence has actually been decreasing for, I don't know, 10 years, goes down slightly. Sorry, I misunderstood.
I hear you. I mean, it's really hard for me too, because I see the benefits of genetic counseling for those kiddos that wind up being just carriers. So yeah, it's kind of hard for me to know that that's the direction that we're going.
I just wanted to follow up on your comments about that. Some of the data that didn't show about the variability in access to genetic counseling at CF centers kind of led to the decision that babies didn't need to be referred to a CF center for CF-specific genetic counseling, but they definitely a general prenatal counselor. That's kind of what that letter. And we have been talking about following up on whether families are taking action about that. So that's something that we can.
Thank you.
Hi, oh, that's loud. Katie Singh from California. So I'm curious how often you get a pickup with the very high IRT. California has all these years of sequencing, but doesn't have a very high IRT fail-safe. And I'm curious what your yield is with them.
So the number that that make it to that category that we are performing testing for, it's a couple hundred a year.
Sorry, can you say that one more time?
Sorry, it's a couple hundred a year.
I mean, how many end up being positive? Like, how many do you identify?
It's
A small
small.
fraction.
So in 2023, we had one case that was homozygous for a likely path
The
variant.
one that you had up
Yep.
on the screen, and no
Yes.
other ones?
No, not in 2023. We've had others, but it's rare now because we've made these improvements to our IRT reporting and testing algorithm. It is more rare now.
Thank you. Great talk.
Thank you. Thank you, everyone.
Sorry, can I just ask one more question? I couldn't see over there, and I don't remember from the prior slides. What is your ultra-high IRT level?
So it is a 10-day rolling top 0.1%. So
Okay.
it's quite high.
Okay. And then some states have said setting not necessarily a ultra-high IRT level, but they've recommended like a fail-safe of like above 65 nanograms per milliliter or something like that. Do you have that kind of a fail-safe?
We have that fail-safe on our top 5%, actually. We don't have it on our ultra-high category, but if our top 5% dips below, I think it's 55 nanograms per mil, we reflex to the panel anyways.
That's a really nice
Yeah.
fail-safe.
Yeah. Thank you.
So I'm very happy to introduce Angelique. And Angelique, as mentioned earlier, is a pediatric genetic counselor at Ann and Robert H. Lurie Children's Hospital in Chicago. And she has a special interest in CF newborn screening. She has a wealth of knowledge and experience in CF. And, oh, you know what? I was supposed to go back to our slides, wasn't I? Okay, let me do that. So you could see her. Yep, thank you. We knew this part was going to be a little clunky, but there we go. Now you can read the wealth of knowledge and experience that Angelique brings to our session. And one fun fact, she enjoys throwing murder mystery parties with her family and friends. And she loves figuring out clues and solving puzzles, which is probably why she's a genetic counselor, right? So please welcome Angelique.
All right, good morning, everyone. As mentioned, my name is Angelique Mercier. I'm a genetic counselor at Ann and Robert H. Lurie Children's Hospital of Chicago. Very excited to be talking to you guys today about the Cystic Fibrosis Foundation evidence-based guideline for the management of CRMS CFSPID applications for genetic counseling practice. Okay. And there are no relationships to disclose related to this presentation. So my plan for today, I'm going to start by reviewing the guideline and some of the recommendations, and then specifically discuss practical applications for genetic counselors, as well as applications for other providers and some future directions. Okay. So for this guideline, a multidisciplinary committee was formed, which developed an evidence-based guideline for the management of cystic fibrosis, transmembrane conductance regulator-related metabolic syndrome, cystic fibrosis screen positive, inconclusive diagnosis, which I'll of course refer to as CRMS CFSPID because we do not have time to say that every single time. A total of 24 patient intervention comparison and outcome or PICO questions were generated, and these were based on surveys sent to people with CRMS, CFSPID, and clinicians caring for these individuals, also taking into account previous recommendations and expert committee input. Then a systematic review of the evidence was conducted, which found numerous case series and cohort studies, but no randomized clinical trials. And from that, a total of 30 recommendations were graded using the U.S. Preventive Services Task Force methodology, and recommendations that received greater than 80% consensus among the entire committee were approved. And so these guidelines are intended to be used by both CF specialists and primary care providers or PCPs. And there's an emphasis on shared decision-making among these. All right, so as we all know, cystic fibrosis newborn screening has been offered in many countries around the world and in every US state since 2010. And an unintended consequence of CF newborn screening is the detection of infants with an abnormal CF newborn screen result, but inconclusive diagnostic testing, which has been termed CFTR-related metabolic syndrome or CRMS in the United States, and CF screen positive inconclusive diagnosis or CFSPID in other parts of the world. And as a quick review, people with CRMS CFSPID is defined as those with an abnormal CF newborn screen result and either a sweat chloride of less than 30, so in the normal range, with 2 CFTR variants, at least one of which with unclear phenotypic consequences, or a sweat chloride of greater than or equal to 30 to 59, intermediate or borderline, with 1 or no CF causing variants. And this guideline that I'll be talking about today does not address how CRMS or CFSPID is diagnosed because others have already described that. And again, emphasizes that care decisions and these recommendations should be made on a case-by-case basis with shared decision-making. All right, so now for the recommendations. They're broken down into 4 categories: genetics, monitoring, treatment, and psychosocial communication. Given the focus on sort of implications for genetic counseling practice specifically, I'll concentrate more on the genetics and the psychosocial communication categories, but there are lots of recommendations in the other categories as well. All right, so I'm going to start by reviewing the genetics recommendations. So the first one is if it's recommended that for people with CRMS, CFSPID who have less than 2 disease-causing variants identified by newborn screen, they should undergo sequencing of the coding and flanking regions and deletion duplication analysis of the coding and exon flanking regions of CFTR. And so when we talk about the sequencing, it's usually referring to next generation sequencing or NGS. And that's typically what's offered by many, although not all, commercial laboratories that include CFTR testing. And in many people who have CF, this does identify a second variant. But this type of sequencing does not typically cover deep intronic regions of the gene. And there are also other limitations of NGS. Typically, NGS is more limited in its ability to detect large structural variants like exon deletions or duplications, although every lab is a little bit different in the exact technology that they use. So it's really important for genetic counselors and other care team providers to clarify, hey, what testing was done as part of that newborn screen or subsequent laboratory testing. And as already discussed, and you guys all know, regular monitoring of databases like CFTR2 and ClinVar can be helpful to stay updated on classification of CFTR variants as these do change over time. And as already mentioned, newborn screening differs state by state, and the specific type of genetic testing on newborn screening varies. The variant panels often used can be limited to well-established CF-causing variants and may not identify variants of varying clinical consequences. And so given that there are limitations in either the newborn screen or CFTR sequencing, which is often done by next generation sequencing, that led to this next recommendation of selectively offering full gene CFTR sequencing, including intronic regions, if previous testing is non-diagnostic. And some of these in non-coding regions, so intronic, upstream, downstream. Some of them may be classified as variants of uncertain significance due to them being considerably less well-studied than other variants. So things to keep in mind when counseling about this type of testing. And there's typically limited availability, at least right now, for this type of CFTR testing, but this is expected and hoped that over time, this type of testing will be more available. And this may be kind of selectively offered and considered in situations where maybe there's a higher suspicion of reclassification to CF due to higher sweat chloride testing results getting closer to 60 or increasing over multiple tests. And really the reasoning behind this is establishing the genotype is important for diagnosis, monitoring, genetic counseling, and then if reclassification to CF does occur in these individuals, it can be useful for the approval of CFTR modulators. So the next recommendation under genetics is that it's recommended that CFTR genetic evaluation for parents of people with CRMS CFSPID when phasing the CFTR variants would inform the diagnostic status of the individual. Parental testing can often help determine if the variants are in cis, so on the same copy of the gene or trans and opposite copies of the gene. And this can be very helpful for the patient themselves, but can also impact reproductive decision-making and risks for parents of the individual with CRMS CFSPID and also their family members, like the parents, siblings, things like that. The next recommendation is the CFF recommends offering CFTR genetic evaluation for siblings of people with CRMS CFSPID. And the focus here is on kind of having that conversation and offering the evaluation. Evaluating siblings of people with CRMS CFSPID can identify at-risk individuals who may also benefit from clinical monitoring and follow-up. The assessment should be offered in a way that promotes shared decision-making between the families and the care team, because there are some risks and benefits, such as kind of many people may want to delay this until childbearing age for that sibling so that they can share in the conversation. And then the next recommendation is that for families of people with CRMS CFSPID, it's recommended that healthcare providers, professionals providing genetic counseling should have training or clinical expertise in CF and genetics. A licensed or certified genetic counselor should be accessible to families of people with CRMS CFSPID for further support, including discussions regarding future reproductive decision-making. All right. I think that was a really important thing that the guidelines mentioned too, is just having genetic counselors available. Some families may prefer to have these discussions with providers outside of the CF Care Center, but at regular intervals during the lifespan, this should be available. All right. So there are many recommendations under the monitoring and treatment sections. I'll just kind of highlight the ones pertaining to genetic counseling. So the first one I'll mention is the recommendation for people with CRMS CFSPID, at least annual follow-up by a CF clinician and nurse with an initial assessment to include a social worker, a mental health coordinator, and or a genetic counseling provider. Continued follow-up by a social worker, a mental health coordinator, and or genetic counselor should be a part of the care of CRMS CFSPID, depending on the needs of the individual and family. And so with the primary goal of monitoring people with CRMS CFSPID being to detect those individuals who may be reclassified to CF, they may not always need, every single care team member, because as mentioned earlier, it's also equally important to avoid over-medicalization of otherwise healthy individuals, because that has its own set of adverse consequences. However, the genetic counselors are a vital part of the team, especially with their expertise in CFTR variants. The other recommendation I'll mention is the recommendation that for people with CRMS CFSPID, implementation of standard CF infection prevention and control guidelines in the healthcare setting and situations where there's a high likelihood of being in close contact with multiple people with CF or people with CRMS CFSPID. However, the implementation of these guidelines in non-healthcare settings such as schools may have significant negative psychological effects that outweigh potential benefits and is therefore not recommended. I mention this one because oftentimes if a genetic counselor is meeting with a family in clinic, it can be helpful to know to sort of set some expectations on, what some of these guidelines might look like and help with families. So there are additional specific recommendations for monitoring and treatment that are also really important. One of them I'll just point out is repeating sweat chloride at 6 months of life and annually at least until age 8 years. So I encourage everyone to take a look at the specific recommendations when you have a chance, but for sake of time, I'll just keep going. And then the final category are psychosocial and communication recommendations. So I'll start by kind of reading them through and then kind of summarizing the highlighted points. So the recommendation is for people with CRMS CFSPID that healthcare providers assess and consider social determinants of health that can influence the understanding and psychological impact of a CRMS CFSPID diagnosis and tailor communication appropriately. The next is that healthcare providers tailor communication about CFTR variants based on shared decision-making to minimize psychological, cognitive, and other barriers to processing and understanding genetic information. The next recommendation is using clear, concise, consistent, and timely information about the uncertainty related to CRMS CFSPID, and that's communicated using family-centered communication strategies. And then the next one is that for people with CRMS CFSPID and their families, gradual, clear, and consistent verbal and written developmentally appropriate education is provided at diagnosis, at follow-up visits, and at the time of reproductive decision-making. And then the final one is that it's recommended that for people with CRMS CFSPID, that PCPs and other healthcare providers involved in the care of individuals with CRMS CFSPID receive accurate and up-to-date education about CRMS CFSPID, its management, and their state's newborn screening program. I apologize, I know that was just a lot of information. I just wanted to kind of highlight the main recommendations in that category because they're all pretty relevant to kind of genetic counseling practice. And really what a lot of them get at is the diagnosis of CRMS and CFSPID is associated with a lot of uncertainty. And it's been shown that a perceived lack of knowledge of the person communicating newborn screening results has been linked to parental distress. So it's vital that team members are knowledgeable and consistent in their discussion of the diagnosis and the follow-up plan for patients. And these recommendations really highlight minimizing barriers to understanding the complex information and tailoring communication to this specific family. And many of these things are things that genetic counselors already do and value in communication and how we work with families and providers. So when thinking specifically how these can be applied to families with CRMS or CFSPID, really emphasizing clear, consistent, timely information. Considering parental learning preferences, providing information in multiple ways, so verbal, written, audio-visual if possible, providing this information in a patient's preferred language, so if it's a language that somebody speaks or using an interpreter. Reviewing this information at multiple time points can help questions as they arise. And CF Care Centers should serve as a resource with current information for PCPs to help educate and clarify newborn screening results, CFTR testing results, sweat chloride, or other evaluations that pertain to the diagnosis. And PCP should be informed on when to seek advice for symptoms that could present over time. And really, communication with PCPs should highlight the reasons for more frequent reassessment by the CF Care Center. Okay. So as genetic counselors, how can we utilize these recommendations and guidelines into our practice? So starting at the very beginning, a diagnosis of CRMS CFSPID is based on newborn screening results. So I know that the newborn screening process is different state by state and country by country, but this is sort of how the CF newborn screening process works in Illinois, which is where I live and practice, and is specifically pertaining to my institution. So first, the state lab receives the sample, processes the IRT and DNA, and then reports the abnormal newborn screen for CF to the PCP or the NICU, et cetera. The PCP then informs the family of the abnormal newborn screen, and then the PCP places a referral to the CF newborn screen program. How it works at our center is that the family then calls to schedule a visit. They're scheduled within a few days. They speak with someone the same day and get their initial questions answered. And then they have their newborn screen visit, which is ideally scheduled within a day or two, a couple of days. At that time, they have their sweat test. They meet with a genetic counselor to review the results, pulmonology providers as well, depending on those results. And then ideally, we get a diagnosis, either normal or CF, or sometimes we're at CRMS, CFSPID. And so in thinking about that, the genetic counselor may be the very first person who is speaking with families in detail about the newborn screening results. PCPs and other providers may have questions about the results or next steps. Genetic counselors may be very involved in their CF newborn screening program or may not. Certainly it's an opportunity to potentially get more involved either at the institution or state level, especially for genetic counselors who have a lot of background and knowledge about CF and genetics. And that really getting back to that idea of this perceived lack of knowledge of the person communicating the results has been linked to parental distress. So if the people that families are communicating with are really knowledgeable and know a lot about this information, that could be helpful overall. All right, and some additional kind of applications for genetic counselors. The guideline does highlight the importance of having a GC and genetic counseling services as part of the care team, individuals with training and expertise in CF and genetics, and then really just having a licensed or certified genetic counselor accessible to patients. Just because there is a lot of uncertainty with the exact trajectory of individuals with CRMS and CFSPID, it's important to keep these communication tips handy, although I know as genetic counselors we do this a lot, but making sure information is accurate, up to date, communicated clearly and concisely, and having kind of follow-up visits or conversations that may provide the benefit of just clarifying information or providing more, addressing new questions as they arise. And there are many kind of counseling approaches that GCs already use in multiple settings, but I wanted to kind of point out, because they're especially helpful with uncertainty, is really matching the timing and amount of information shared with the parent's needs as appropriate or as possible, showing empathy to parental distress and as appropriate, instilling a sense of hope, personalizing the counseling approach because it's not going to be the same for every family or even the same family at different time points, offering even things like acts of hospitality like water, snacks, a more preferred room if possible, utilizing teach-back methods to check in on the family's understanding of what you're reviewing, using a distraction-free environment, ideally if you could visualize the family, either face-to-face or something like that, and just really keeping in mind that it's going to be very unique for each family, as well as keeping in mind social determinants of health, which have a major impact on individuals' kind of well-being and overall experiences. All right. Some additional kind of practical applications for genetic counselors. This does provide evidence-based guidelines supporting the importance of genetic counseling for not just the person with CRMS, CFSPID, but also their parents and their siblings. Potentially, this could provide evidence to support requests for things like insurance coverage. I know that I'm very involved with insurance prior authorization, so anytime I can cite something that suggests that, hey, we should be, providing the service to families or at least talking about it can always help. And really having access to genetic counseling services, throughout the lifespan, really happens when genetic counselors are integrated into the CF care team. So it's always good to see that. All right, so as far as other providers, the guidelines do talk about this. So just briefly, it mentions frequency of follow-up for things like sweat chloride testing, respiratory cultures, laboratory testing, pulmonary function testing, radiographic imaging, and comments about things like different treatment things. Repeat sweat testing I'm going to mention specifically because that is part of what could reclassify an individual to having a diagnosis of CF, as well as the reclassification of the CFTR variant. So highlighting how important genetic counseling and genetic counselors are to the CF team and the care of individuals with CRMS and CFSPID. All right, I don't know if that showed up super great or not, but I'm a table person. This is table 4 from the guideline paper. I like seeing things kind of in one spot, so if I'm not sure if it showed up okay, check out the paper if it doesn't show up great. Just kind of says, hey, what are the interventions? When to consider it, when to perform it, and this can be employed both with a CF care center as well as a primary care provider. And then finally, some limitations. As I mentioned earlier, there are no randomized clinical trials of people with CRMS CFSPID that have been reported, but there are some really exciting future research directions that I would love to kind of see out there. And I know some of these are likely already underway, but really just gaining a better understanding of the CFTR variants, following individuals with CRMS CFSPID over time, including addressing development of CFTR-related disorders, assessment of clinical benefits of various treatments in those with CRMS or CFSPID, and then as more people with CRMS CFSPID are followed over time, reassessment of these recommendations will be required, and hopefully we'll have a ton more information in the future. All right, so lots of people to acknowledge. I was very, very honored to get to work on these guidelines with these amazing authors, and special thank you to the Cystic Fibrosis Foundation. So thank you to everybody of them. And thank you to the entire team of the Division of Genetics, Genomics, and Metabolism and the CF Center at Anna and Robert H. Lurie Children's Hospital of Chicago, where I work. And this was a photo of the genetics department taken on Rare Disease Day this year. So we're very excited. All right, well, thank you guys so much. Happy to answer any questions.
Thank you so much.
Hi, I'm Becky Dira. I've got a couple questions
Yeah.
from Case Western Reserve. So I'm curious about people's thoughts on this age 8 thing. So I've had 3 kids convert in the last 6 months, and they were age 10 and 2 were 17. So I'm a little nervous about sending any message that if it hasn't happened by age 8, you're good. I know that's not how it's stated, but I think we just have to be really careful. So I'm curious about that. And my second thought is, and this comes up, I think, even with Dr. K's presentation, and sort of like maybe the knee jerk with that is, all right, well, they know it, and then we can reflex to the primary care docs. At least another scary case I had in the last month was a 17-month-old who came in intubated because of respiratory disease, such bad failure to thrive, and this girl was not going to survive much longer. Somebody decides to sweat her eventually in the ICU, and she's, of course, has CF. I'm like, what happened? She's Delta F homozygous. How is this missed? Well, the parents had elected for a home birth, and no one ever did newborn screening. So I went back to the pediatrician. I'm like, what happened? Oh, well, we assumed the newborn screening was normal because we never got any kind of messaging. So maybe that was just a lousy pediatric practice, but I think we have to be really careful, because I think people are putting a lot of stock in that somebody else has looked at all this. And it's not at the top of anyone's radar right now that, okay, well, newborn screening would have caught, X, Y, and Z. So just curious on your thoughts on that.
Yeah, great points. If it's okay, I want to address the second one first. I think that it is so important that PCPs and providers get this education. And I know kind of almost unrelated to the specifics with talking about CRMS and these guidelines, so I've worked at Lurie Children's for almost 9 years now doing CF newborn screening. And I've definitely fielded a lot of questions from pediatricians saying, could this be CF, but the newborn screen was normal? So it's a lot of education and saying it is a screen. If it's negative, if there's still clinical concerns, and even like a baby who's maybe had one mutation, normal sweat, and we've discharged as, carrier, we'll still say, if symptoms arise, please, look into it. So I think that sort of goes along with how I'm envisioning the recommendation about communications and education with pediatricians, both for saying newborn screen's not perfect for any condition, specifically CF, and I mean, all conditions. So I think that's really important. And also, like, if you don't know if someone, they could have been born in a different state that might have had different things. I know you mentioned in your case it was a home birth. So I think that's why education for pediatricians and healthcare providers is so, so important. So thank you for that point. And then the first one, I do not want to misspeak. I know that it says sweat testing at least until age 8. I cannot recall off the top of my head if it goes into what to do after, and I don't want to misspeak on that, but it did say at least, so.
I can take the sweat piece if you want, because I'm the one who was tasked with sweat. So I can answer it for you.
Okay, thank you.
We had to look at literature that was published about newborn screening. The latest conversion I could find in the literature about someone who had a newborn screen and then converted was 7. That's where 8 came from. And it says at least because there wasn't data beyond 8. And I know it can happen. It's not like, as you know, the older you get, the less likely it's going to be. And that's very specifically why it says age 8. And then there's a line in there that this should be revisited at some point in the future, because the literature just didn't exist beyond that.
Thank you.
Thank you. Great talk. My first
question comments was in exactly the same vein around age 8. And I think these guidelines are really helpful. But CFTR2 does a nice job, and some other publications do a nice job of emphasizing symptoms or presentation of CF or CFTR-related disorders may emerge or change across the lifespan. And I think we have this big gap of people who have been born in the era of newborn screening and people who haven't. And what's the conversion rate by age 8 is one thing, but by age 80 is another thing. So a little plug for a talk I'm giving Saturday morning about a new diagnosis in an 80-year-old who obviously was born before newborn screening, and then her 71-year-old sister based on sibling testing. I'd love to see longitudinal work trying to elucidate the risk for CFTR-related phenotypes across the lifespan. And then also thinking about our education of these families, we don't want to over-medicalize, but if we're dismissing them from practice at age 8, how many 8-year-olds themselves are going to remember that if they develop a chronic cough or they can't conceive or something, that there might be risk for a CFTR-related disorder based on their early CRMS diagnosis. So I suppose that's more of a comment, though I welcome your input. My other question, comment, I suppose I'll frame it and then pose a direct question. I feel like there's an emerging category of uncertainty. CRMS, of course, has been an area of uncertainty, but there's this category of patients that I feel like don't fit any box, including CRMS, which are those with at-risk genotypes ascertained in non-traditional ways. So say we do test a sibling of a CRMS kid and they have the same at-risk genotype, but they themselves had a negative newborn screen. It's my understanding we can't technically call them CRMS unless they had a positive newborn screen. Correct me if I'm wrong.
That's my understanding as well, so yes. There we go.
Then we have an era of babies being born to CF moms who've been on modulators, and we know that they're at risk due to parental genotypes. And we do diagnostic genetic testing in an infant who had a negative newborn screen, and it's false negative due to the medication mass. Or women who are turning up with at-risk genotypes on their own prenatal carrier screening. So some of these kids, we've made the clinical decision that the best application of the categories we have is really to follow the CRMS guidelines, especially for those little ones with potentially at-risk genotypes who had a negative newborn screen, negative sweat test, but they're exposed to Trikafta prenatally, and at this point still through breast milk, that we're going to follow them loosely on a CRMS schedule. But we don't have a good box for what to call those people.
Yes, I completely agree. And I was just nodding along something. Yes, exactly. I think this often comes up a lot too with, so I'm very involved in the CF newborn screening program at my institution, and we'll get calls from parents where both parents were found to be a carrier of a CFTR variant. So maybe it's a 5T in one parent and a Delta 508 in the other or something. And some of those babies are not actually even flagging, or maybe both parents are 5T carriers and they're not flagging on the newborn screen, so they don't have an abnormal newborn screen, but we're still evaluating and there is no great category. So I would actually love to see more clarity or clarification, for babies like that in that situation in the future, because I think with the amount of carrier screening that's offered and being taken up, I think this is just going to keep coming up. So I don't have an answer, but I'm right there with you. I agree. Let's figure it all out. So
Thank you. Thank you for clarifying my understanding that the technical definition of CRMS is positive newborn screen.
correct, and that is my understanding as well. And it's very hard because every state and much less country has different people flag different ways. So I mean, there's probably a world where a baby might flag in one state but not in another, and how could that lead to a different diagnosis? I'm not sure. So.
I have no answers or clarity, but I invite you to come to a consultation clinic on Saturday morning where at least one case will be this exact situation where it's an at-risk genotype. So the consultation clinic is diagnostic and counseling challenges. It's Saturday morning at 8 o'clock, sorry. Eleanor is presenting a case about an at-risk genotype, and if you've never been to these consultation clinics before, it's a lot of like facilitated discussion. And so one of the questions is going to be, what is the right thing to call these patients? So I have no clarity, but perhaps the people in that room will.
Thank you.
Just a quick comment, and then we do have one question for Dr. K, and then I think we're at time. But my question is, there's going to be updated newborn screening guidelines that are coming up. Some of you are, yep. So I just wonder if there's going to be any guidance related to special requests that our newborn screening labs would need to consider. For example, please check this baby who's a sibling of a kid with CRMS regardless of IRT. I can't remember. I know I've seen them, but I just don't remember.
We get those requests in New York. I don't think there's anything in the guidelines
Okay.
specific to that.
There's no recommendations. Okay. Because I know different states do entertain those special requests. The problem is they're varied, and sometimes even we have an amazing newborn screening lab and algorithm situation, but some of my siblings, I can't even get tested. And then I'm in a quandary when they have both variants. Anyway, sorry. And what question for Dr. K?
Can I just ask, have you tried requesting that the newborn screening program pulls the blood spot of the sibling and just does the test?
So, yeah, we have a problem because they will only, like, so if I have a sibling that's going to be born, I can contact our state lab, but they will do the DNA testing regardless of IRT only if it's not a VVCC. If it's a VVCC, then we cannot do that.
Okay.
So that's where I'm stuck.
I think there was one question in the chat for you, Dr. K, around what is the turnaround time for your newborn screen for CF?
So most of our results are, the reports are issued on day 7. So, and that's business days. And we used to release them on day 4. So it's really added 3 days to the testing procedure, which in the grand scheme of things, we have not found that it's led to delayed diagnoses. In fact, again, we find that a physician knows the baby has 2 CF causing variants, they're going to act real quick.
Yeah, absolutely. It saves weeks compared to sending, sequencing, following one
And-
variant being detected and then sending it to a clinical lab, waiting for results on that.
Yeah, and we test every day. We're a large volume state. Some states don't do genetic testing every day. We do a batch a day.
Thank you, everyone. Are there any other last questions? Great. Thank you for the great discussion.
Thanks to our lovely presenters, and it was amazing. Thank you.
Thank you.